Okay, so now we're going to talk about some other complications of labor, and some of these are emergencies, and then there's lacerations tacked on at the end. So first, an amniotic fluid embolism. A bolus of amniotic fluid gets into maternal circulation either before or during the birth. So this is more likely to happen if they're having a precipitous labor, they're just going really, really fast, if they're induced, if they have an abruption, or if they have too much amniotic fluid. And all that kind of makes sense, right? What does it look like? The patient is in sudden respiratory distress or arrest. They have circulatory collapse. They develop pulmonary hypertension, which you can't see from looking, but you'll see the sudden respiratory distress. They have cor pulmonale. They may hemorrhage because they can use up all their clotting factors and go into DIC. They'll be in shock. They may go into a coma, and this has a very high mortality rate. Management, you're going to call a rapid response as soon as this is suspected. If it's before birth, they're generally going to do a C-section, both in an attempt to save the fetus and also because it's you're much more likely to have a successful resuscitation on a pregnant patient if the baby's removed. If the patient survives, they get supportive care in ICU to manage the DIC and ARDS-like symptoms. This is really scary. This is in labor and delivery, you're get that baby delivered, rapid response. If they survive that, they're probably going to have ARDS and be in DIC. So then they go to ICU for that care. Precipitous labor is a labor that's less than 3 hours, and it's often associated with a precipitous birth, meaning they give birth so quickly that a provider doesn't get there. The risk factors, this is more likely the more babies they've had, if they have a large pelvis and a small fetus, if they've had a previous precipitous labor, if they have strong contractions, stronger than typical, and if they're induced. The complications, the baby can deliver so quickly that the cervix doesn't have time to dilate, so it can cause cervical dilations, and that the perineum doesn't have time to stretch, causing perineal lacerations. This is a difficult labor to cope with. These patients often feel like they've been strapped to the front of a train. I was present at one of these labors, and it was a 17-year-old. And I'm pretty sure she grabbed the back of my arm, and I'm pretty sure she separated the muscle just a little bit because it hurt for 2 months after that. The risk of postpartum hemorrhage is higher, and the risk of fetal hypoxia is higher. When the baby is born very, very quickly, they're compressed in the vaginal canal, and then if they pop out too quickly, the head and the thorax can expand too rapidly and cause cerebral trauma in particular, disrupt some blood vessels and cause a bleed, or a pneumothorax in the chest. Management, a patient who has a history of precipitous labor may be induced to avoid an unintended out-of-hospital birth. The nurse needs to be prepared for emergency delivery, and delivering in sideline position may help control the delivery more and decrease the speed of delivery. Shoulder dystocia is another scary one. This is when the head delivers and the shoulders do not. Risk factors, fetal macrosomia, so a big baby is a risk factor, but it's most significant if the mother's also diabetic. The complications, you have about 5 or 6 minutes to get the baby delivered before irreversible hypoxic brain damage, because blood keeps going to the head, but the veins are compressed and it can't get back out. So the head becomes suffused with blood, and eventually there's so much pressure in the head that it prevents arterial flow into the head as well. The complications, fetal death or anoxic brain injury. In the attempt to get this baby delivered, the clavicle may be broken, or they may have a brachial nerve injury. Management, there are a lot of different maneuvers that are used to attempt to deliver this baby. The first, which has the most success, is usually McRoberts. The patient, you want to recline the patient more. You want to hold their legs in close to their body and flex them as hard up against the abdomen and chest as you can, while someone puts suprapubic pressure, not fundal pressure. You want pressure right above the pubic bone, not at the fundus. If that doesn't work, there's a series of other maneuvers. But this one is one of the ones that you we've got to get the baby out. The next complication is non-reassuring fetal heart pattern. There are two major causes, and we've really talked about this some. Cord compression can cause a sudden hypoxic episode, or placental insufficiency can cause more chronic hypoxia, or it can cause hypoxia that appears with increased demand. So they may be okay until they go in labor and then start showing signs of placental insufficiency. The adverse outcomes are hypoxic brain injury and death. Management, if we can correct the cause, we correct it. If it's persistent and it's a long time till delivery, or if it's severe, the provider is going to go ahead and do a C-section most of the time. Nursing care, we reposition the patient, stop any meds that are inducing labor, increase the IV, and give oxygen. A prolapsed umbilical cord is when the cord actually comes out before the presenting part. That's more likely to happen when the membranes rupture with too much fluid, or if the baby's not in a head down presentation. The complications can cause hypoxic brain injury and death because the cord can begin to dry out or will become compressed when the baby's delivering. Management, whoever discovers it gets to keep their hand in and try to keep the presenting part off of the cord until the C-section. If any cord is protruding from the vagina, it needs to be covered with gauze moistened with sterile saline to prevent it from drying out. Now, we talked about all the scary complications. Now we're going to talk about lacerations. Lacerations are very common in delivery. Their perineal lacerations are classified by degree. Now, we can have lacerations at other areas. They can be near the clitoris, near the urethra. We can have cervical lacerations, vaginal lacerations. The most common location is the perineum, that space between the vagina and the anus. A first degree affects only skin and subcutaneous tissue. It may or may not even need sutures. Okay. A second degree involves the muscle. Any episiotomy is automatically going to be second degree most of the time. So that's going to need the muscle repair and then the skin repair. A third degree laceration involves the anal sphincter, and a fourth degree goes completely through the rectum. The anal sphincter is transected. Third and fourth degree tears increase the risk of long-term fecal incontinence. Also, patients who've had lacerations and episiotomies frequently complain about chronic pain and sexual dysfunction. Episiotomy is also a site for infection. So management is the provider does a very careful repair. With really severe tears, they may need to go to a specialist. The first repair has the best chance of being successful. So if they have a fourth degree tear, they really need someone who's very good at it to do that. As a nurse, we are monitoring that recovery and monitoring for signs that the repair's not been successful. Okay, in the next section, we're going to talk about postpartum.